Hello everyone, welcome to Medicuisine. Today we are going to talk about Myasthenia gravis. Myasthenia gravis is a disease of the neuromuscular junction in which there is impaired transmission of signals across this neuromuscular junction, which is also called the motor end plate, resulting in some symptoms like weakness and fatigability. So weakness and fatigability are the hallmark symptoms of the myasthenia gravis. Moving on to the pathophysiology of myasthenia gravis, it is an autoimmune disease. So the first thing you should note about myasthenia gravis is it is an autoimmune disease, most commonly caused by antibodies against acetylcholine receptors at the postsynaptic membrane and the postsynaptic membrane at neuromuscular junction. What happens basically is autoimmune response. There is production of autoantibodies against the acetylcholine receptors which are present on the postsynaptic membrane at the neuromuscular junction. The antibodies destroy these acetylcholine receptors. The response which actually muscles give to the signals, to the incoming signals, is affected, which results in weakness and fatigability. So the hallmark symptoms, the weakness, fatigability, results from destruction of these acetylcholine receptors on the postsynaptic membrane at neuromuscular junction or the motor end plate. Remember, regarding the pathophysiology of myasthenia gravis, in 80% of cases it is these antibodies against the acetylcholine receptors which destroy these receptors, resulting in poor response of muscle to the incoming signals. And 20% of cases, it is other antibodies which produce myasthenia gravis. Most notably, antibodies against muscle-specific kinase. Muscle-specific kinase. So, in 80% of cases, it is the antibodies against the acetylcholine receptors, and 20% of cases there are other antibodies involved in the pathophysiology of myasthenia gravis, most notably the antibodies against muscle-specific kinase. Muscle-specific kinase is responsible for regulation and maintenance of acetylcholine receptors. So remember this concept regarding the pathophysiology of myasthenia gravis. Now let's talk about the clinical presentation of myasthenia gravis. It usually presents between ages of 15 and 50 years. Most commonly, it affects individuals from 15 to 50 years of age. There is female preponderance in younger patients, and in older patients, males are commonly affected. Myasthenia gravis classically follows a relapsing remitting course. What is a relapsing remitting course? In this type of course, the patient experiences relapses, which are actually the periods of flares of the disease. The symptoms got worse. The symptoms got worse, or there are onset of new symptoms. These relapses are followed by remissions, which are the periods of partial or complete recovery. So the classical symptoms of myasthenia gravis, this is muscle weakness and fatigability, the most evident symptoms. There is worsening of symptoms towards the end of the day or following exercise. So muscle weakness and fatigability following exercise or towards the end of the day, this is very characteristic of myasthenia gravis. In the later parts of the video, we will discuss a differential diagnosis of myasthenia gravis, which is the Lambort Eaton Myasthenic syndrome, which also presents with the same clinical symptoms like muscle weakness and fatigability. These symptoms actually resolve as the day progresses. As the muscles contract more and more, these symptoms actually resolve. But in myasthenia gravis, the symptoms actually get worsened as the day progresses. As they are utilized, they actually weakens. Remember, ocular, facial and bulbar muscles are the first to be affected in myasthenia gravis. These three types of muscles are the first muscles which are affected in this disease. Ocular muscles, facial muscles and bulbar muscles, the muscles of articulation and muscles of swallowing. So initially the patient presents with symptoms related to these muscles like ocular symptoms, ptosis, diplopia. So facial weakness, which is manifested as snarling appearance when smiling. The snarling appearance occurs when the patient tends to smile, when the patient tries to smile. The snarling appearance is also called myasthenic snarl, which is an aggressive type of facial expression specifically due to poor retraction and elevation of the corners of the mouth. So remember the snarling appearance when the patient smiles, the ocular symptoms, ptosis, diplopia, and due to involvement of the bulbar muscles, there is difficulty swallowing and the speech may get affected, resulting in a speech having mushy or nasal quality. As the disease progresses, other muscles are involved, especially muscles of the shoulder girdle, and the weakness becomes generalized. Actually, we have got two different types of myasthenia gravis. One is the ocular type and one is the generalized type. In generalized, we will discuss these two types in a few minutes. But remember, the first manifestation of the disease occurs with these ocular symptoms, facial symptoms or bulbar symptoms. But as the disease progresses, as more and more muscles are involved, the weakness becomes generalized. Especially when the shoulder girdle is involved, the patient is unable to undertake tasks above the shoulder like combing of hair. Because the shoulder girdle muscles are involved, the patient becomes unable to undertake these tasks above the shoulder like combing of hair. Respiratory muscles may be affected in the very last stages of the disease, and this can actually cause the death of the person when these muscles become involved. So these are the two types of myasthenia gravis we were talking about earlier. The ocular myasthenia gravis, when the disease is confined to the eye muscles only, and generalized myasthenia gravis, when there is generalized or widespread involvement of muscles. Along with the eye muscles, the facial muscles are involved, the bulbar muscles are involved, and there is muscle involvement of the shoulder girdle also. Then this disease is called generalized myasthenia gravis. The prognosis of ocular myasthenia gravis is really good, but the generalized myasthenia gravis, this can cause problems actually. Remember, with all these clinical symptoms we discussed, there are certain things you should remember. The pupillary responses are normal in myasthenia gravis. Deep tendon reflexes are intact, and there is no sensory abnormalities. No sensory abnormality, deep tendon reflexes are intact, pupillary responses are intact. So these three things you should remember regarding myasthenia gravis, which remains normal. There is a classical clinical sign regarding myasthenia gravis which you should know about. Cogan's lid twitch sign. Cogan's lid twitch sign. When you ask the patient to gaze downward and return to primary gaze, the affected lid will briefly twitches upward. This actually comprises this Cogan's lid twitch sign. Let's talk about the investigations and diagnosis of myasthenia gravis. Remember, the best initial test for the diagnosis of myasthenia gravis is serology, where we look for the acetylcholine receptor antibodies. This is a very specific test. This is a highly specific test because the presence of these antibodies along with the typical symptoms like the weakness, fatigability, based on these two things only, you can establish diagnosis. But there's a problem. These acetylcholine receptor antibodies are present in only 80% of patients. The 20% of patients may be seronegative for these antibodies, the acetylcholine receptor antibodies. They have antibodies but against the other factors like the muscle specific kinase actually. So if the acetylcholine receptor antibody test is negative, the patient is seronegative, you should look for antibodies against the muscle specific kinase also. The edrophonium test, the famous edrophonium test, the tensilon test, is sensitive but not specific for the diagnosis. And we are not doing this test anymore. It is obsolete now because we give edrophonium IV to patients who we want to investigate for myasthenia gravis, and the patient may experience cholinergic symptoms like salivation, lacrimation, diarrhea, blurred vision. So due to these symptoms, due to these cholinergic symptoms, we don't do this test anymore. And also this test is less specific. Imaging studies of the chest like X-rays and CT scan, they should be performed. Why we do chest X-rays and chest CT scan? To detect a thymoma, because many of these patients who present with myasthenia gravis may have thymoma, and more commonly they have thymic hyperplasia. Like 10 to 15% of patients have thymoma, and thymic hyperplasia occurs in about 65% of patients who present with myasthenia gravis. Remember, the most accurate test for the diagnosis of myasthenia gravis is EMG, electromyography. And on electromyography, we get a characteristic finding, the decremental decrease in muscle fiber contraction on repetitive nerve stimulation. When you repetitively stimulate the muscle fiber, there is smaller and smaller response. The response gets smaller and smaller with time, the decremental decrease. Now we are into the management of myasthenia gravis. Remember, the goal of treatment is to maximize the activity of acetylcholine at the remaining receptors, because most of the receptors, they get destroyed due to the autoantibodies produced against them. The receptors which remain, we actually try to maximize the activity of acetylcholine at these receptors, these remaining receptors. And the second goal is to limit the immunological attack on the motor end plate. The motor end plate is also called neuromuscular junction. So the immunological attack which is launched against the acetylcholine receptors, we should limit this immunological attack in order to treat the disease, in order to symptomatically treat the disease. So the first class of drugs which are used in the management of myasthenia gravis are the acetylcholinesterase inhibitors, which are used for the symptomatic relief only. And the acetylcholinesterase inhibitors used in myasthenia gravis are neostigmine and pyridostigmine. The pyridostigmine is long-lasting as compared to neostigmine. These anticholinesterase inhibitors are associated with muscarinic side effects. Muscarinic side effects like lacrimation, like salivation, and they're controlled by propenthyline. So propenthyline is for the muscarinic side effects of neostigmine and pyridostigmine. Now, if the acetylcholinesterase inhibitors fail to provide the symptomatic relief, we go for immunosuppressive therapy. Immunosuppressive therapy is second-line therapy in myasthenia gravis. So if acetylcholinesterase inhibitors fail to provide symptomatic relief, we go for immunosuppressive therapy. And the initial immunosuppressive of choice are the steroids, the glucocorticoids. And if glucocorticoids also fail to provide the symptomatic relief, we add azathioprine. An alternative to azathioprine are cyclosporine and cyclophosphamide, which have more side effects as compared to azathioprine. So glucocorticoids plus azathioprine if glucocorticoids alone fail to provide symptomatic relief. You can actually replace azathioprine with cyclosporine or cyclophosphamide, but they are more cytotoxic and more side effects they have more side effects as compared to azathioprine. So you should keep thinking that also. What is acute myasthenic crisis? This is a life-threatening condition where there is acute exacerbation of myasthenia gravis with prominent bulbar and respiratory symptoms. Actually, when the disease progresses, it involves more and more muscles. And when respiratory muscles are involved, there are respiratory symptoms. Along with respiratory symptoms, the bulbar symptoms get worse. And an acute exacerbation of myasthenia gravis occurs, acute myasthenic crisis. And this is a life-threatening condition. And how we actually manage this acute myasthenic crisis? This is a very important discussion. So, in cases of acute myasthenic crisis, we need rapid improvement. We need the symptoms, the prominent bulbar symptoms and the respiratory symptoms to be reversed on urgent basis. So, for this, we give IV immunoglobulin and we do plasmapheresis. So, the plasmapheresis and IV immunoglobulins are for acute myasthenic crisis cases. And the acetylcholinesterase inhibitors and immunosuppressive therapy, they are for the chronic management of myasthenia gravis. What is the role of thymectomy? Does this thymectomy have any role in the management of myasthenia gravis? Thymectomy has its role actually. It is indicated in post-pubertal patients and in those aged less than 60. So post-puberty and less than 60 with generalized myasthenia gravis before the initiation of immunosuppressive therapy. So what this means is when you try acetylcholinesterase inhibitors and they fail to provide symptomatic relief, before initiation of immunosuppressive therapy, you should try thymectomy. So you should do thymectomy before the initiation of immunosuppressive therapy. Remember, the initial immunosuppressive of choice, these are steroids, these are glucocorticoids, and then you go with the cytotoxic drugs, azathioprine, cyclosporine and cyclophosphamide, etc. So if you do thymectomy and the symptoms of the patient are relieved, there is no need of the systemic steroids and the cytotoxic drugs like azathioprine, cyclosporine and cyclophosphamide. So you actually want to prevent these potentially toxic medications used for the management of myasthenic crisis, for the management of myasthenia gravis. The second benefit is it is performed to prevent the spread of malignant thymic disease. Remember, I told you that thymectomy is indicated in those patients who have generalized disease and have thymoma. So two things, generalized disease and thymoma. And the patient should be also post-pubertal and less than 60. This age, generalized disease and the patient have a thymoma. Thymectomy should be performed. Thymectomy should be done before the initiation of immunosuppressive therapy. Now, if the patient is a younger patient and the patient is seropositive, there are antibodies against the acetylcholine receptor. Seropositive, there is generalized disease, but there is no thymoma. These patients can also benefit from thymectomy. Remember, I told you that patients who have generalized disease and have thymoma, they benefit from thymectomy. This is indication for thymectomy. But those patients who have generalized disease but no thymoma, but these patients are younger and seropositive, they can also benefit from thymectomy. Mycophenolate is a newer immunosuppressive with less side effects as compared to azathioprine, cyclosporine and cyclophosphamide. So you can actually replace these cytotoxic drugs with this less toxic mycophenolate. Remember, always avoid immunoglycosides and quinolones in patients who have myasthenia gravis, because these drugs, especially immunoglycosides, they actually enhance the blockage at the neuromuscular junction, enhance the blockage of signals at the neuromuscular junction, so worsening the symptoms of myasthenia gravis. So always avoid immunoglycosides and quinolones, especially immunoglycosides in myasthenia gravis patients. There are certain differentials of myasthenia gravis which present with the same clinical features, the muscle weakness and fatigability. You should be able to differentiate among all these conditions, and they include the Lambort Eaton Myasthenic syndrome, the botulism. So let's briefly discuss the Lambort Eaton Myasthenic syndrome. These patients also have muscle weakness, plus they also complain of autonomic dysfunction, like they complain of dry mouth. In Lambort Eaton Myasthenic syndrome, there is impaired neuromuscular transmission of signals due to antibodies against the presynaptic voltage-gated calcium channels. Just like myasthenia gravis was having Cogan's late twitch sign, Lambort Eaton Myasthenic syndrome also has a cardinal clinical sign, the absence of tendon reflexes. Which return after sustained contraction of the relevant muscle. So as I said earlier in this video, that as you use muscle, the muscles gets better in Lambort Eaton Myasthenic syndrome, while in myasthenia gravis, as you use muscle, the symptoms worsen, the muscle weakens. If with use the muscle gets better, it is Lambort Eaton Myasthenic syndrome. So there is absence of tendon reflexes, but these tendon reflexes return after sustained contraction of the relevant muscle. When you use this muscle, the tendon reflexes return. This is a cardinal clinical sign of Lambort Eaton Myasthenic syndrome. Remember, majority of cases of Lambort Eaton Myasthenic syndrome, they are associated with underlying malignancy. So you should investigate the patient for having any malignancy, especially investigate the patient for small cell carcinoma of the lung, because most commonly this Lambort Eaton Myasthenic syndrome is associated with small cell carcinoma of the lungs. On EMG, there is post-tetanic potentiation of motor response. The motor response gets better actually to nerve stimulation at a frequency of 20 to 50 per second. So with actually time, as you repeatedly stimulate the muscle fiber, the motor response gets better. For treatment of Lambort Eaton Myasthenic syndrome, we use 3,4-diimmunopyridine or pyridostigmine plus immunosuppression. So immunosuppression plus this acetylcholinesterase pyridostigmine or 3,4-diimmunopyridine actually. There is another condition which also presents with muscle weakness and fatigability. This is botulism. We will discuss this in the infective disease of the central nervous system and some other lectures, but let's differentiate this botulism from myasthenia gravis. In botulism, the pupils are dilated and there is incremental increase. So there is incremental increase in muscle fiber strength contraction. So there is incremental increase in muscle fiber strength or muscle fiber contraction. While in myasthenia gravis, we were having decremental decrease in muscle fiber strength on EMG. When we were repetitively stimulating the muscle fiber, there was decremental decrease in muscle fiber strength. while in botulism there is incremental increase in muscle fiber strength on EMG. So this was all about myasthenia gravis. I hope you understand well. If you have any question, please comment down.